to the tubes of the lung, and ectasis is Greek for dilatation or distension of a hollow organ. Bronchiectasis is therefore defined as irreversible airway dilatation, often accompanied by chronic inflammatory exudate. It is essentially an accumulation of structural damage caused by pathological processes, i.e. a structural endpoint of disease. Classification of bronchiectasis is via CT. This includes cylindrical bronchiectasis, the most common form, cystic, and the less common varicose form. Mixed forms also exist. Another subtype of bronchiectasis is known as traction bronchiectasis. Let's start by defining the word traction to help us understand this better. Traction means the drawing or pulling of something over a surface. Traction bronchiectasis is seen in interstitial lung disease such as pulmonary fibrosis. We know that fibrotic tissue has different mechanical properties to normal tissue, including being less flexible. This property leads to areas around the fibrosis being pulled on by this tissue, leading to distortion of the bronchi. This is traction bronchiectasis. Think about how a large scar affects the tissue around it. This term is frequently used in radiological reports, but its etiology has to be understood for these reports to be useful. So let's discuss the causes of bronchiectasis. The most common known cause of bronchiectasis is chronic repeated infections. Followed by this, it is cystic fibrosis and then immunodeficiencies. However, about 50% of patients with bronchiectasis have no traceable cause. Chronic infection is the most common known form and includes infections such as pertussis, pneumonia, TB, and fungal infections, often at times developing a severe infection in childhood such as whooping cough, results in damage to the lung parenchyma, resulting in repeated infections and development of bronchiectasis. Next, we look at defects of mucociliary clearance, of which cystic fibrosis is a part of. The mucociliary escalator is an innate defense mechanism consisting of cilia and mucus. The mucus layer lines the surface of the epithelium, capturing inhaled particles. The cilia then beat and move mucus out of the lung. The mucus part of this escalator is of a special kind. It is called airway surface liquid and has antibacterial properties and white cells. The ASL consists of two parts. One part is a mucus component that does the particle capturing, and the other part is known as the periciliary liquid layer, PCL. Now the function of the PCL is essentially to keep the mucus at a suitable distance away from the cilia so the mucus does not hinder cilia movement. Imagine a conveyor belt transporting strawberry jelly. As long as the jelly is at a suitable distance from the cogs that drive the conveyor belt, then everything would work fine. However, if the cogs were submerged in jelly, then this would hinder its job. The mucociliary layer is also damaged by smoking, which causes temporary acquired ciliary dyskinesia and also causes shortening of cilia, which makes mucus clearing more difficult. So cystic fibrosis is the second most known cause of bronchiectasis. Defects in the CTFR gene mean chloride ion transport is hampered. Essentially, this leads to an alteration in the ASL layer, making clearance harder. Stagnant mucus therefore predisposes to repeated cycles of inflammation, resulting in lung damage. More on that later. Alpha-1 antitrypsin deficiency. So, alpha-1 antitrypsin deficiency is an inherited disorder where mutations in the SERPINA1 gene lead to dysfunctional alpha-1 antitrypsin molecule. This is important because it counteracts the function of the potent neutrophil elastase released in inflammatory responses. However, if this enzyme is no longer running, then neutrophil elastase runs without being adequately controlled. This results in collateral damage to the lung parenchyma, predisposing the patient to bronchiectasis and emphysema. Now, primary ciliary dyskinesia is a rare disorder, as the name suggests, a dysfunction in cilia leading to abnormal mucus clearance, resulting in repeated infections along with infertility, as the microtubules of the sperm are also affected. 50% of people with primary ciliary dyskinesia have what we call situs inversus totalis, meaning their organs are placed on the opposite side. This combination of primary ciliary dyskinesia with situs inversus totalis is known as Cartagena syndrome. Immunodeficiency is the third most common cause of bronchiectasis, being split into primary and secondary immunodeficiency. Secondary immunodeficiency includes HIV infection, hematological malignancy, and drug-induced bone marrow suppression. Toxic inhalation as a cause of bronchiectasis. What do we mean by this? Well, inhalation injury, typically with acute aspiration. However, there is also something known as chronic pulmonary aspiration. In this, small amounts of aspiration occur over time. This aspirate leads to gradual damage to the lungs due to the acidic content of the aspirate. So here we have what we call a scintigraphy, showing on the right side that the aspirate has ended up in the right main bronchus instead of staying in the stomach or the esophagus as is normal on the left-hand side. Bronchiectasis is also associated with systemic diseases such as rheumatoid arthritis, Sjögren's syndrome, sarcoidosis, and inflammatory bowel disease. Distribution of bronchiectasis can also help us in narrowing down the etiological factors. Most of the factors that we have discussed occur in the lower lobe. Now we will move on to discussing how does this bronchiectasis cycle exactly work. This is best explained by Cole's hypothesis. This states that a vicious cycle of inflammation results in disrupted mucociliary clearance within the lung. This disrupted clearance leads to airway obstruction and predisposes to infection due to stagnant mucus. Infection then results in the inflammatory infiltrate being summoned, resulting in damage and destruction to the lung parenchyma. Ordinarily, with simple infections, the lung can recover and work normally. The problem arises when there are repeated bouts of infection. Collateral damage that occurs includes impairment of elastic tissue and loss of smooth muscle, weakening the bronchial wall. Long-standing inflammation also results in a process called peribronchial fibrosis. The damaged epithelium lacks ciliated cells, being altered to squamous metaplasia. This ineffective cellular differentiation results in further difficulty in removing mucus, increasing predisposition to infection, hence inflammatory insult. As well as damage on a micro level, on a macro level, persisting inflammation may result in the development of what we call bronchopulmonary anastomosis. To explain this, we have to be familiar with the arterial supply of the lung, which is split into two systems. The first system are the pulmonary arteries, which supply the terminal air spaces, and the bronchial arteries, which supply the bronchi and its adnexa. During lung damage, the repair cycle may result in these two systems combining. This results in high pressure from the bronchial arteries entering the pulmonary artery. This leads to further damage, vascular damage, causing hemoptysis. However, more concerning with the arteriovenous anastomosis is when venous blood with lower oxygen saturations enters the arterial supply. This results in a right to left anatomical shunt. This shunt essentially results in a VQ mismatch, as ventilation to the lung has not been altered but perfusion has. The issue is that once the lung detects that a particular area has become hypoxic, blood is directed to the healthier part of the lung. This results in areas of shunt developing a worsening VQ mismatch in a vicious cycle. So here's a diagram showing Cole's hypothesis. Each of the etiological factors discussed fits into Cole's hypothesis at separate points, however they all propagate in a vicious cycle. Symptoms of bronchiectasis include cough, sputum production. This sputum is commonly known to be extremely copious, hemoptysis, shortness of breath, and weight loss, though that is non-specific. Signs of bronchiectasis include crackles, wheeze, clubbing, and again muscle wasting is non-specific. So with investigations, ideally what we would do we would start off with bloods. Full blood count will allow us to see the presence of any superimposed infection. High eosinophil count points towards ABPA, fungal infection, and we can also use rheumatoid factor to check for systemic disease. Testing for alpha-1 antitrypsin is also important. Secondary immunodeficiency testing via HIV, very important. Moving on to imaging. X-ray. So X-ray findings in bronchiectasis are generally non-specific, although thickened airways may be present. CT. This is especially useful when diagnosing bronchiectasis. Several signs can be seen in bronchiectasis. These include the track sign, which is quite common, and the less common signet ring sign, and the cluster of grapes sign. So here is a CT that we have the classic track sign seen in cylindrical bronchiectasis. We also have other investigations that we can do, including nasal nitric oxide test. This can help us diagnose primary ciliary dyskinesia. A low reading may also allude to undiagnosed cystic fibrosis. Initial diagnosis of bronchiectasis occurs via clinical picture. This is then followed by confirmation by CT. Because of the varying causes of bronchiectasis, treatment consists of targeting each stage of Cole's cycle. Respiratory physiotherapist develops a customized plan for each patient, including breathing techniques and use of special devices such as flutter valves. These techniques target airflow obstruction. Mucolytic and mucoactive agents can also be used to help mucus clearance. Carbamazepine is commonly used. These again target airflow obstruction. As well as defective mucociliary clearance. Hypertonic saline can also help in clearance of airways in cystic fibrosis by altering the physical properties of mucus, mainly by increasing hydration of the ASL and increasing cough. It is by the same mechanism that hypertonic saline is used to gather mucus from a patient when cough is unproductive. These treatments target disrupting mucus clearance and inflammation. So, anti-inflammatory agents such as oral corticosteroids can be used in exacerbations. However, these should generally be guided, ideally, with culturing from sputum. Along with antibiotics. Here is a chart showing what antibiotics to use. Prophylactic antibiotic treatment is recommended in patients who have had 3 or more exacerbations per year. a history of severe exacerbations, or if they are chronically infected with P. aeruginosa. Here are recommendations for prophylactic antibiotics. And here are the references used in this presentation. Thank you for listening. If you do have any questions, you can leave them in the comments section below, and I will get back to you again. Thanks again for listening.